hi everyone, and a very warm welcome to you all this evening. It's great to have so many of you joining us for the second webinar in our new clinical series. For those who don't know me, my name is Annie and I'm a support services officer here at Ovacome. I just wanted to remind everyone that myself and my colleagues Anna and Catherine in the support team are here to provide information and support for anyone affected by ovarian cancer. You can get in touch with us via our support line, send us an email, message us via instant chat on our website, through our online forum, My Ovacome, or you can schedule in a time for an individual video call with one of us via Zoom or Skype if that might work better for you. And we also run a whole range of online and now hybrid support groups for people affected by ovarian cancer. The details of all of our support services can be found on our website, and we are here Monday to Friday, 10 AM to 5 PM to talk through any questions or concerns you might have, provide information and relevant resources, or just to have a friendly chat. We're always really happy to hear from you, so please don't hesitate to get in touch with us if you have any questions or this webinar causes any further questions for you or causes anything on your mind. But I'm really delighted to welcome Professor Charlie Gourley, who's the Chair of Medical Oncology and Honorary Consultant in Medical Oncology at the University of Edinburgh, who will be talking to us today about rarer subtypes of ovarian cancer. So I'll pass over to Charlie now. Thanks so much.
Thanks very much, Annie, for that introduction, and thanks, Holly and Ovacome, for inviting me to speak. So I'll just share my screen. I'm just looking, and I think I've got the wrong PowerPoint open. Sorry about that. I'll be open in a second here. Okay. Sorry, I need to just try again. Here we are. Can you see that okay? Is that appearing okay?
Yeah, I can see that.
Great. Perfect. Okay, good. Right. Well, thanks again for asking me to speak. I'm going to talk about rarer subtypes of ovarian cancer. These are my disclosures or conflicts of interest. So what I'm going to talk about the fact that ovarian cancer is more than one disease. It can't be treated as a single entity anymore. When I started treating ovarian cancer about 25 years ago, we did treat it as one disease, but now it's become clear that that's the wrong approach to it. And I'm going to discuss new approaches to understanding the biology and testing new drugs in some of the rare subtypes: low-grade serous ovarian cancer, endometrioid ovarian cancer, clear cell ovarian cancer, and mucinous ovarian cancer. So this whole story about ovarian cancer being more than one disease, well, ovarian cancer, believe it or not, the majority of it probably doesn't actually arise in the ovary. So high-grade serous and low-grade serous, they may well actually come from the fallopian tube. A lot of endometrioid ovarian cancer and clear cell ovarian cancer actually may well arise from endometriosis. And actually, the rarest subtype, mucinous ovarian cancer, it may be the only one that we think comes consistently from the ovary. So over in this pie chart, you can see that the most common type of ovarian cancer is high-grade serous ovarian cancer. And of course, this is very important. And but there has been a lot of research into high-grade serous ovarian cancer, and a lot of new drugs have been produced to treat high-grade serous ovarian cancer. But the rarer subtypes, low-grade serous, endometrioid, clear cell, and mucinous, have been far less deeply studied. And we need to know a lot more about them and get much better treatment options for them. And so, as well as potentially coming from different cells in the body, these different ovarian cancer subtypes respond differently to chemotherapy. They respond differently to radiotherapy. And they've got different genes driving them. You can see I've written some of the genes down here. And these are just a few of the genes. Now, with the new sequencing technology we've been able to look in a bit more depth at the biology driving these cancers. And so until about the last 10 years, ovarian cancer treatment was based on this one-size-fits-all approach. But as I say, it's now clear that that's no longer appropriate. Some of the subgroups have only been recognized really quite recently. I mean, low-grade serous was only identified as a separate entity in 2004. And that may seem like a long time ago, but actually it's it's fairly recent to realize that this is a completely separate disease. And as I've said, many of the subgroups may well not come from the ovary at all. And in terms of the response to chemotherapy and radiotherapy, well, high-grade serous is the most sensitive to chemotherapy. Its response rate to chemotherapy is about 70%, 70 or 80%. And what that means is 70 to 80% of patients will respond to their first-line chemo. Whereas for some of the others, such as low-grade serous ovarian cancer, the response rate to chemo is probably less than 10%. Clear cell ovarian cancer is the most radiosensitive, the most sensitive to radiotherapy. And so they are clearly very, very different. And the problem this creates for us is that many of the clinical trials that we use to guide how we treat patients even today were done at a time where we put all ovarian cancer together. So what that means is when we see a new patient in the clinic and we think about the stage of their disease, then the data that we use to say whether we should give them chemotherapy or not comes from a time when all of these were lumped together. And that means that the results from those trials that were done 20 or 30 years ago would largely be driven by high-grade serous because that was the most common type of ovarian cancer. So we can look at those trials that say, well, we should give patients with stage 3 disease carboplatin and paclitaxel chemotherapy. But really, what those trials tell us is we should give high-grade serous patients carboplatin and paclitaxel chemotherapy. You can hardly say that a mucinous cancer should be treated the same way when maybe only 3% of the patients in that trial had that sort of cancer. So what it means is we're having to look back and we're having to change our idea about the evidence. And, in medicine, we like big randomized clinical trials. What that means is clinical trials that compare a new treatment to the old treatment and include lots of patients, and which a computer decides whether the patient gets treatment A or treatment B. So at the end of the trial, you can compare the two groups. But the problem is, when you've got rare cancers, it's quite difficult to get a trial as big as that. And it requires international collaboration in order to achieve that. So sometimes we have to make do with evidence that isn't quite as good as that. So what we might have to do is we might have to look back through our databases for all the patients, say, that had clear cell ovarian cancer, and look at whether we gave them chemo or not, and then try and work out whether we felt they responded to that chemo or not. Now, that data isn't as high quality data, but at least when we do that, we can be sure that all the patients we're looking at have the same histology, the same subgroup of ovarian cancer. And indeed, it has become clear when we do that, that some of these subgroups respond poorly to chemo. As I've said, high-grade serous responds well, low-grade serous much less well to chemo. Endometrioid ovarian cancer somewhere in the middle, clear cell ovarian cancer somewhere in the middle, mucinous ovarian cancer, well, again, it depends on what sort of mucinous ovarian cancer it is. However, increasing our understanding of the biology helps us find new drugs to treat these rare cancers. And this is what we're really trying to do just now. And that's what I really want to talk about today. So I'm going to tell you how we do it in Edinburgh. obviously, there are many good centres around the country who are doing similar things. So this is our cancer centre where patients get treated, they get seen and treated for their cancer. But the thing is, about 50 yards away is our cancer research centre. In fact, this is a whole big institute that does genetics and does cancer research. And in this new building along the front, we've got more than 100 bioinformaticians. And so what bioinformaticians are these are really statisticians or mathematically trained scientists who will take sequence data that we provide them with, or data from tumours telling them which genes are switched on and which are switched off, big data, massive data, and they'll crunch through it. And the fact that we've got all these bioinformaticians to analyze this data has really helped us work out what's going on in some of these cancers. Now, it isn't all just because of the resource we've got now. I need to pay credit to one of my predecessors, who is, this is Professor John Smythe. He was the first professor of medical oncology in Edinburgh. And he decided at a time when I was playing computer games on my ZX Spectrum that the best use of computer power at that time in 1982 would be to create an ovarian cancer database. And he created a database that's now got more than 5,000 patients on it. And what that means is that we can go back and we know what happened to all of our patients that came through. We know what chemo they got, we know whether they responded, and that turns out to be a really valuable resource. On its own, it would be quite valuable, but because we also have all the tumour samples from all our patients, and this is an example of a tumour block that we've got, and after somebody has an operation for anything really, but particularly for cancer, the block is stored for 20 or 30 years. And so we've been able to go back and get the block. John Smythe, who set this up, when he set it up, there wasn't a technology to look at the sequence of the genes from these old tumour blocks, but there is now. So I've been able to harness this along with the help of this chap who is the professor of gynecological pathology, Simon Harrington, and he looks at all of these samples to make sure they are the sort of ovarian cancer that we think they are, because the definitions change over time. And then with my lab group here, they then do the analysis, the molecular analysis, and we try and work out what it means for patients to have one of these rare cancer subtypes. And then, of course, once we find information like this, we try and find drugs to treat patients, and we transfer that information back into the clinic. And so, we should really have another arrow at the top of this figure showing that the information goes in both directions. And this figure is really just to show that, we have done work. These are papers that we've published in all of these rare subtypes: low-grade serous, endometrioid, clear cell, and mucinous. And I guess the point is that some of these are clinical trials. Some of them are looking at the genes that are switched on or switched off. And some of them are just looking back to see how patients have done and whether we can divide them into groups of patients that will do well and maybe don't need much more therapy, and groups of patients who do less well and therefore may need more therapy. And so at the end of the day, the idea is that we will take this understanding of our rare ovarian cancer biology, and this figure here is something called an oncoplot. Don't worry too much about the detail. But essentially each vertical line is a patient or a patient's tumour, and each horizontal line is a gene. So at the top of this is a group of cancers, and at the top of this, these are low-grade serous cancers actually. At the top of this are all the patients who had mutations in a particular gene, KRAS, and then those who had a mutation in another gene, BRAF, and then as you go down, the mutations become less frequent. But we take this molecular information and we say, well, that means that those tumors might respond to this drug or that drug. And then we give it to cells that are growing in the lab. And the idea of this is it will then inform clinical trials. which we do in the hospital. And then even once we're running the clinical trials, if, for example, a patient responds for a while to a drug and then stops responding, then we may well ask them for a biopsy of the tumor to try and work out what has changed in the tumor that has made the patient resistant to that drug. And so it's this two-way flow of information between the clinic and the lab that helps our understanding of what drives cancer and what makes patients resistant to these drugs. Okay, so that's the sort of more general background. Now what I'm going to do, just for the next 20 minutes or so, is talk about some of these specific rarer ovarian cancer subtypes. And the first one I'm going to talk about is low-grade serous ovarian cancer. So it's quite rare. It accounts for about, well, just under 10% of all serous cancers, and it accounts for maybe 5% of all ovarian cancers. It generally affects younger women. The median age is 43, so that's about 20 years younger than the median age for high-grade serous ovarian cancer. But unfortunately, many patients are in their 20s or 30s. And in fact, I have had a patient who was only 19 when she was diagnosed with this sort of cancer. It's relatively resistant to chemotherapy, as I've already said. And most patients are diagnosed in advanced stages. And unfortunately, quite a lot of patients with either stage 2, stage 3, or stage 4 disease, their cancer will relapse at some point. Now, it is possible to live for quite a long time, even when the cancer relapses. But what we need to do is we need to find more therapies to make that quite long time even longer, if you understand what I mean. And because we've kind of realized over the last 10 years or so that this sort of ovarian cancer is fairly resistant to chemotherapy, that's led to a search for new drugs that are not chemo drugs. There is some evidence that drugs like letrozole or anastrozole, which are sort of hormone drugs, or a drug called bevacizumab, which blocks the blood supply to the tumor, there's evidence that these drugs have some activity. Now, the evidence for these drugs comes from those what we call retrospective studies, where we look back and see how patients do. So it's not the highest level of evidence, but it is quite convincing. And so it has changed our practice to some extent. But what we started doing recently is doing some clinical trials to try and show the benefit of new therapies compared to the standard of care. Now, this is a big challenge, as I've said, because these cancers are rare. And in order to do these big trials, you need plenty of patients. But we found with low-grade serous ovarian cancer, if we collaborate internationally, then we can do this. So I'm now going to tell you about a trial of a new drug. First of all, before I do that, I need to just mention a bit about the biology, and apologies for the figures that look a little bit complex. I will simplify these as we go. But basically, studies have shown that there are certain genes that are mutated in low-grade serous ovarian cancer. And they're mainly these genes, RAS and RAF. And what these genes do, these form proteins in the cancer cell. And they're part of what's called a signaling pathway. So all your cells in the body have got a cell membrane and a nucleus. And the nucleus is the control center. And a message comes in from outside the cell through the cell membrane. And it's these molecules that send that message through to the nucleus to tell the cell what to do. And these pathways control whether the cell will divide or whether it will survive. And what happens in cancer is a mutation causes the pathway to always be switched on. So regardless of what's going on outside the cell, the center of the cell will get a message to tell it to keep dividing, regardless of what's going on. And that's what causes the cancer. So this is a bit of a simplification of that diagram. We've got the outside of the cell here. We've got this thing called a receptor, and then we've got this pathway with RAS and RAF and MEK and ERK. And this is the nucleus that controls what's going on. So if we've got RAS mutated, then this signal is going to be switched on all the time. But one of the drugs that we used in the trials is a drug called trametinib, which blocks this molecule, which means the signal doesn't get past here. And so the theory is that in patients in whom RAS and RAF are mutated, and actually it turns out in other low-grade serous ovarian cancers, blocking this signal can really help. And so that led us to do a study of this drug, trametinib, where we compared it to standard of care treatment. So patients, half the patients got trametinib, and half the patients with low-grade serous ovarian cancer got either letrozole, which is a hormone agent, or tamoxifen, which is a hormone agent, or one of 3 chemotherapies. And this was up to the doctor who was looking after them. And then we then followed the patients to see how long the cancer stayed away for. Now, this is something called a progression-free survival curve. So this is the duration of time that the cancer stays away. The best way to think of these is if there's a big gap between the 2 lines, then the patients on the top are doing better. And actually what we found was that in the patients who got the trametinib, they relapsed half as quickly as the patients who got the standard of care therapy. And this was the first time that there'd ever been a positive randomized trial in low-grade serous ovarian cancer. When we looked at the percentage of patients who responded, those who got the trametinib, 26% responded and 59% had stable disease at 3 months. In the control arm, the percentage of patients who responded was only 6%, although there were quite a lot who had stable disease. Response means that the disease actually shrinks. And then, of course, as well as looking at how well the drug works, we also have to look at how toxic it is. And there was a fair incidence of skin rash. About 92% of patients got a skin rash, but we can control that with antibiotics. And there was some fatigue and some diarrhea and some other side effects, although I would say they were largely manageable. So, where are we now with low-grade serous ovarian cancer? Well, we understand that the disease is different from high-grade serous ovarian cancer and that chemo is not particularly effective. Drugs such as letrozole and bevacizumab seem to also have a role in this disease, although that's not been definitively demonstrated in a randomized trial. And it actually probably never will, because these drugs they're out of patent. So it'd be quite difficult to do that. Not impossible, but quite difficult. Trametinib, this drug that blocks the signaling of that pathway, is the most effective agent when the low-grade serous ovarian cancer comes back. But we need more therapies. There are clinical trials of new agents going on right now. I'm going to mention another one of those just now. And also, we're trying to find drugs in the lab that are effective. And as soon as we find them, we're going to get them into the clinic. So remember this figure where the trametinib blocked this signal. Well, we're now doing a trial of another drug, not quite as easy to remember the name of, it's VS6766, but rather than just blocking MEK, it also blocks RAF. So the theory is it gives a stronger blockade of this pathway. And in an early study that was done with this drug, it did seem that it worked in some patients who'd already progressed on trametinib. So there's a trial currently underway looking at this drug and also looking at this drug in combination with another drug. Don't worry about the detail of this slide. This is to remind me to tell you that my group are doing a drug screen in the lab where we're growing these low-grade serous ovarian cancer cells in the lab. And we're using a robot to seed the cancer cells into lots of tiny wells. And then we're exposing them to 1,800 different drugs to try and find which drugs kill the cancer cells the best. And we're getting through all of these agents, and we have had quite a few hits. That means we've identified some drugs that seem to have some efficacy. And some of these drugs actually are already licensed for other cancers, but nobody's thought to try them yet in low-grade serous ovarian cancer. So we're quite excited. And once we've done a bit more work, we really hope to set up some clinical trials to test these drugs in patients. And so this is just a demonstration of how we can shift between the lab and the clinic. So the next cancer I'm going to talk about is endometrioid ovarian cancer. It accounts for about 11% of all ovarian cancers. Some are high grade, and they actually behave very like high grade serous ovarian cancer. Others are low grade, and they may arise from this disease endometriosis, which is a sort of inflammatory disease that can happen in women, mainly running up to the menopause, mainly when they're premenopausal. Some of these low-grade tumours actually have a very good prognosis, but relatively speaking, very little research has been done into endometrioid ovarian cancer. So I'm going to tell you a story about how we analysed in quite a lot of detail the genes. You don't have to worry about any of the fine detail. It's really just to show how this can be done and how we've sort of really shone a bit of light on what the genetic landscape of this cancer is. So we used our database, the database I told you about with 5,000 patients, and we looked back to see how many had been called endometrioid ovarian cancer, and there were about 500. But obviously this goes back now for 40 years. So we tried to, for 216 we couldn't find any tumour, but for 289 there were tumours. But some of them, on review by our pathologist, turned out not to be endometrioid. So we actually only ended up with 112. But we sequenced these, and we sequenced the whole coding genome. What that means is we sequenced all the genes that produce proteins. And this was the biggest sequencing study that's ever been done in this disease. And again, here's one of these plots showing the genes that are switched on in the tumor. Again, please don't worry about this. I'm going to just highlight some for you. So we found this, this gene CTNNB1. And what we found with that was that patients who had mutations in this gene, also known as beta-catenin, they did really well. So actually, those patients that had these mutations, their survival disease-free was 90% at 10 years. And then we found some other genes. I'll not mention that one too much, but this gene is quite important because this is a gene that's associated with endometriosis, and patients with mutations in this gene did better than some of the other ones. This is another gene that seemed to also confer a better prognosis, as did this gene KRAS, which interestingly is also important in low-grade serous. Now, P53 is a gene that's commonly mutated in cancer, but in endometrioid ovarian cancer, it conferred a worse prognosis. So patients who had a mutation in P53 did worse. But what this allowed us to do was really work out two main groups of patients. So patients with P53 mutations, about half of whom presented with stage 3 or stage 4 disease, so that's more advanced disease. And most, they had a high instance of it not being possible to remove all their tumor, and their survival, unfortunately, was worse. Whereas these patients with CTNNB1 mutations, only 11% had advanced stage disease, and they were very frequently had a good operation. And their survival was better even after we corrected for these factors such as stage and amount of debulking. So it allowed us to make a sort of model of endometrioid ovarian cancer where we had three groups. Beta-catenin group did very well, P53 group unfortunately did poorly, and then there was a group in the middle that had mutations in neither. Now, the reason why this is important is that at this point in time, nobody has tried to stratify how we treat endometrioid ovarian cancer. And with this group in particular doing extremely well, I think we need to look at the possibility that these patients don't actually need any chemotherapy and spare them the chemotherapy. Whereas for this group that appear to do, relatively speaking, much more poorly, this is the group that we need to focus our efforts on, and also obviously not forget about the group in the middle either. So where are we now with endometrioid ovarian cancer? Well, we have a much better understanding of the biology of the disease. But as yet, this knowledge isn't being put into clinical practice. And so we need many more clinical trials in endometrioid ovarian cancer, and we need to clarify which patients don't need any chemotherapy because their underlying prognosis is so good, and we need to work out better therapies for those patients who clearly have a worse prognosis. Okay, so this is the second last subgroup of ovarian cancer I'm going to talk about, and this is clear cell ovarian cancer. Constitutes about 11%, often presents at early stage. So, you know, because it often presents at early stage, it can often be cured by the surgeon. Not always, but often it can. And like endometrioid ovarian cancer, these cancers can often arise from endometriosis as well. Now, clear cell ovarian cancer is more common in the Far East, in Southeast Asia and Eastern Asia. Japan really has the highest incidence, but there is, generally speaking, a higher incidence in Southeast Asia. And in terms of the response to chemo, it's an intermediate response rate to first-line chemo, maybe around 30%. But unfortunately, if the cancer comes back, the response rate to chemotherapy in that setting is quite poor. But these are the ovarian cancers that respond best to radiotherapy. Now, this curve here on the right-hand side is from British Columbia. And usually when we show two different treatments on the same curve, it means this is that there's been a randomized study. And this wasn't a randomized study. So what this was British Columbia, essentially Vancouver. They had 6 oncologists, and 3 of them thought you should just give these patients chemotherapy after they had their initial diagnosis. And 3 of them thought you should give them 3 lots of chemo, but also give them some radiotherapy. And so, therefore, they kind of split quite nicely into 2 groups. And the patients that got the 3 cycles of chemo and the radiotherapy seemed to do a lot better than the patients who got 6 cycles of chemo. Now, it's a bit controversial, this study, because it's never been, you know, it's not a proper randomized study. But some of us believe it's enough evidence to offer patients with 3 cycles of chemo and radiotherapy. And so in some places, radiotherapy will be offered, and we certainly offer it here, but I can understand why some centers wouldn't. And then, as well, there are these anecdotal reports of excellent responses to the drug bevacizumab. Bevacizumab is this drug that blocks the blood supply to the tumor. And unfortunately, again, there have been no big randomized studies done, but quite a few of us have seen amazing responses to this drug bevacizumab. Of course, not in everybody, but I can certainly think of 2 or 3 patients who've done exceptionally well with clear cell ovarian cancer when we've given them this drug. And also, this appears to be the form of ovarian cancer most likely to respond to immunotherapy. Now, you've probably heard that immunotherapy is a great treatment in melanoma and kidney cancer, but unfortunately in ovarian cancer it seems to be less good. Now, the slight exception to that is that in the trials that put everybody in together, it seemed that most of the patients who were responding had clear cell ovarian cancer. And this led to a study, we'll not worry about this just now, and this led to a study called PEACOCK that has just finished in the UK, giving patients this drug pembrolizumab, which is an immune therapy. So this study has just finished, and the results will be announced in September. There's also another trial in the UK called ATARI that's currently going on, and that's testing a drug with a long name called ceralasertib, along with a drug called olaparib. But we also need to work out which of these patients actually need chemo, because we've got a feeling that clear cell ovarian cancer isn't the most chemosensitive. And we know that quite a lot of the early stage patients, the cancer doesn't come back. And so we haven't quite worked out which patients should and should not get chemo. I think we thought we'd worked it out 20 years ago, but that's before we realized that the histology was really different. And so we now have to think again. And let me just also mention this. It's a complicated figure, don't worry too much about that. But there's often been this question about whether Asian clear cell is the same as Western clear cell. And until recently, all of the sequencing studies have been done in Japanese or Korean patients. But we did a study in Edinburgh where we sequenced the main genes. And what we found was the frequency of mutations was exactly the same as it was in these Japanese and Korean cohorts. So I think that from a molecular perspective, the diseases are the same. And that's important because that means that when we do clinical trials, we can put patients into the same study without worrying too much about there being a different biology. And so the last subgroup I'm going to talk about is a very rare subgroup called mucinous ovarian cancer. Makes up about 3% of all epithelial ovarian cancers. It often presents at early stage, and often the tumors are also at low grade. And actually, again, quite a lot of them can be cured by the surgeon. Unfortunately, some do come back, and some are higher grade and a bit more aggressive. There have been recent papers, and we've contributed to these as well, that have shed a lot more light on the biology of the cancer. So we didn't really have enough patients here to do, a full analysis on our own. So we put them into a pot with patients from North America and Australia. An analysis was done, and it was possible to work out what the key genes were. And it also showed, or it also provided evidence that these cancers probably come from benign and borderline, which is somewhere between benign and malignant, tumors of the ovary. And so that's quite important because it gives us an idea of how they go from being a normal cell to being a cancer cell. I guess the main problem in this cancer is it's been very difficult to perform these randomized clinical trials. So about 12 or 13 years ago, a big effort was made to do a randomized trial in mucinous ovarian cancer. And it was led by this real kind of icon of medical oncology in the UK called Martin Gore. He's sadly no longer with us, but he led this trial with a plan to recruit 330 patients from across the USA and the UK. But it turned out that the recruitment was extremely slow. And the reason the recruitment was really slow was because it was really, really hard to identify these patients as they came through. So this taught us a few lessons about, which patients you can put in these randomized trials, and maybe there are just too few mucinous patients. Whereas low-grade serous, even though it's maybe only twice as many patients, it seems to be easier to get them into randomized trials. So what do we do with these mucinous patients? We've got to do research in this setting. So there is another solution. And that solution is to take a number of rare cancers, rare ovarian cancers. And this includes low-grade serous or mucinous or clear cell. Take these rare cancers and do molecular analysis. NGS stands for next generation sequencing. And based upon the mutations that are present in the tumor, then the patients then get a test arm, a test treatment arm. So in this top arm, patients with P10 mutations, PIK3CA or AKT1 mutations would get this combination of drugs. Patients with BRAF, KRAS, NRAS or NF1 mutations would get this drug, and so on. And if they didn't match to any of the molecular abnormalities, then they would go into a catch-all group at the bottom. And so the good thing about this is that it's looking for a signal that the drugs work. It's only putting 20 patients into each arm. And if they get a signal that it does work, then they'll expand out and they'll add another 30 patients into the arm. And by doing this, it means even the really rare tumors can be included in a study and get access to these new therapies and also get their tumor molecularly tested, and so therefore get put on drugs that they're more likely to benefit from. In addition, this setup allows us to add new arms on, and actually there are another 4 new arms due to be added into this trial in the next 3 or 4 months. Okay, so it's really important to understand that ovarian cancer is more than one disease. In some of the rarer subtypes, response to chemotherapy is poor, but there's potential for less toxic molecular therapies to be used, or at least to be tested within clinical trials. And we need to select the patients for these trials on the basis of the biology of their cancers. And then very rare cancers, platform studies such as the BOUQUET study that I just showed you, may help get access to new agents for these patients. So that's really me. I'd just like to acknowledge the LOG study was the low-grade serous study, to thank all the women who participated, their families, and all the centres that contributed around the world. And then these are some of the collaborators that have collaborated in our other studies. And again, thank patients and relatives and some of our funders. Okay, I think that's me. I will stop sharing. Oh, I think you're on mute, Annie.
Thank you. That's great. Thank you ever so much, Professor Gourley, for your extremely informative and comprehensive presentation. We're very grateful for your time and for sharing your expertise on this topic. And Professor Gourley has kindly agreed to answer some of the questions that have come in. So thank you to everyone who sent these in today. Let me just find this first one. Why are germ cell tumours and sex-cord stromal tumours such as granulosa cell tumours not included in your rare tumours list?
Yes, no, that's a very good question, and I apologise if you feel that's an oversight. So they come from a different bit of the ovary. So I guess what I focused on here is epithelial ovarian cancer, and this is, these are through development of the ovary, there are several layers, and germ cell tumours come from the germ cell, and granulosa cell tumours come from the sex cord stromal cells that are developed, and they are different from the epithelial ovarian component. So I apologise for doing that. So germ cells tumours are a kind of whole different really a whole different avenue. And in fact, quite often they're not even treated by doctors who treat ovarian cancer. They are in some centres, but in some centres they aren't. So, for example, in our centre, they're mostly treated by the doctors who treat male germ cell tumours. We do, however, treat granulosa cell tumours and sex cord stromal tumours. And these, again, they're a bit like some of these rare ovarian cancers in that they're under-researched. And, and because they're also rare, we need to work together with our international colleagues to find new treatments. And also, the extent to which they respond to chemotherapy is variable. And so we're having to look for new molecular therapies. So, yeah, I mean, I'm happy if somebody has a specific question about them, I'm happy to answer that later offline, but I guess I focused on the main epithelial ovarian tumours.
Thank you very much. The second question, someone has said, curious to hear what are Professor Gourley's thoughts on a frontline combination of trametinib and bevacizumab for low-grade serous ovarian cancer? And are there any reasons that they cannot be used concurrently?
So, yeah, so first-line treatment, well, so trametinib, the value of trametinib has been shown in the relapsed disease setting. And so, how can I put this? So one of the issues we've got is that although we've done a randomized trial that's clearly shown the benefit for this drug, at this point in time, it's not licensed for ovarian cancer. It is licensed for melanoma. And so it is possible to get hold of the drug on the basis of the results that have been shown in the study, but it's often required to ask specially for it. But that is in the situation where the cancer has come back. There's been no trial of trametinib in the first-line setting. Now, that may be a reasonable thing to test. I guess the only thing I would say is that the level of toxicity that you get with trametinib, it may be hard to justify that in somebody who's otherwise totally well and whose cancer may not come back. Whereas when you're in a situation where the cancer has come back, then, you know, it's easier to justify, you know, what is a significant toxicity profile. In terms of adding bevacizumab in, so theoretically, I can't think of any reason why not. However, when you do that sort of thing, in an ideal world, you would do a proper test of the two drugs together before you started doing it. You know, so ideally, you'd have a clinical trial showing that putting the two drugs together wasn't detrimental. Although theoretically speaking, I can't think of a reason why it would be.
Great, thank you. And the next question we have is, I wonder if Professor Gourley has thoughts on when low-grade serous ovarian tumours and other rarer subtypes will be genetically tested, and when is the best time to get this done? Also wondering if this is something that can be done privately.
Yeah, so, well, I'll answer the second bit first, and that is yes, it is possible to get genomic profiling done privately. There are a lot of companies that do it. I think it would be great if we lived in an age where we could get everybody's tumor profiled. That's, I think, what most of us are working towards, and we're hoping that that will be possible, you know, with, let's say, within the next 5 years, because, you know, it would certainly help us work out what trials were most appropriate for patients. There is, of course, another way of doing it, and that is if you can get access to the BOUQUET study, and you know, if a patient was going to go on the BOUQUET study, those patients all get something called Foundation 1 testing, and so the results of that would be accessible to them. So there are various routes, and I personally believe it's helpful. You know, it's hard, you know, it's quite difficult to actually say, well, a particular mutation would mean I would definitely give this, whereas if they didn't have the mutation, I definitely wouldn't. But I think it helps give you general guidance.
Great, thank you very much. Are there any trials open at the moment for people with a rare subtype of ovarian cancer who have not had chemotherapy? So quite a general one. Yeah,
that's actually a really good question, and I'm not aware of any, because, and the reason for that is that most of the inclusion criteria stipulate the patient should have had chemotherapy first. Now, that is something that I think we need to change by education, because when the chance of responding to chemo is low, why should we mandate it? I think it's partially to do with the fact that in order to get a license for the new drugs at the end of the day, it's easier to get a license if the patient has progressed at some point after platinum chemotherapy. So I think it's to do with subsequently the drug company being able to license the drug. But I think we somehow need to speak to the regulators and the drug companies and actually get away from that paradigm.
That's brilliant, thank you. So somebody has asked, I just wondered why a lot of trials ask that there has been a disease-free period to be eligible. I'm keen to join one of these new therapies, as I know that more chemotherapy that I'm being offered may not be the answer, but it's very difficult to find any relevant trials or understand who specialises in this area. Any help would be greatly appreciated. Also, are any of these drugs that have had a good response in clear cell available privately, please?
Okay, a few things in there, right? So the disease-free interval thing, again, I think these are inclusion criteria that are related to the drug company have put in order that if they get a positive trial, they can then get a license. Because that sounds, sounds a bit like they're just looking after themselves, but at the end of the day, they need to make money, otherwise they don't bring new drugs through. Usually those intervals are that patients should not have progressed on their first line treatment, but then should have progressed within 6 months of any subsequent treatment. But not all have that. So most of them say, you can't have actually progressed on the first line treatment. And some have this stipulation about having to progress within 6 months of your most recent chemotherapy. And then there was a question about molecular testing. Was it, the pembrolizumab, sorry, yes. So can you just read out the last 2 bits? There were 3 bits to that question.
Yeah, no problem. So very difficult to find relevant trials or understand who specialises in the area. Also, are any of these drugs that have had a good response in clear cell available privately?
Yeah, okay. So, so in terms of finding people who specialise, well, obviously your oncologist will be a specialist. There's no question of that. And you could ask them what clinical trials are available at their centre, at your centre. And if there aren't any that you might be eligible for, you could ask them to refer you. And everybody is happy to do that. And obviously there are centres that have more trials than others, and then you could get referred to those centres in order to get access to the trials. And then, so in terms of the new drugs that seem to be effective in clear cell, you need to be a bit careful because some of the data is not going to come out until September. But some of those drugs potentially, after the data is out, may be available in the private sector, yes.
Thank you very much. So the next question we've got says, I am low grade and 9.5 years with it. If KRAS was identified for my low grade, would drugs for other cancers with KRAS work with low grade? If not, why not? Thank you, Charlie.
Yes, so trametinib is a drug for KRAS mutant cancers. And that is the drug that I would say would be the drug of choice unless the patient has already had it. In which case, I would say that the best thing to do would be to try and get on a trial that would give access to some of these other new drugs or some of these other RAS pathway targeting agents. And so it doesn't necessarily even have to be a trial for ovarian cancer, and there are also centres that do early phase trials in very niche areas, such as new drugs targeting that pathway. So there are 2 options there. I think the trametinib option would certainly be the first one.
Thank you very much. And the next question, someone has said, I've heard that patients are unlikely to be offered clinical trials unless they have first had standard chemotherapy treatment. Is this correct?
Yeah, so this again, we've mentioned this. Unfortunately, that is correct. And I wish we could change that. And hopefully over the next 10 years, we'll be able to somehow change that paradigm. But that's the way it is at this point in time, unfortunately.
Thank you. Someone has asked, you mentioned that with mucinous ovarian cancer, it depends on the type as to how well it responds to chemotherapy. Please, could you elaborate on this?
So yeah, I think of it quite simplistically, to be honest. And so I think of low grade and high grade. Now, I'm aware my pathology colleagues may think of it differently, but I'm not a pathologist. So you get some low grade mucinous cancers, and it seems as though they don't respond very well to chemo, but thankfully those are usually early stage. So usually if I'm having a discussion with a patient who comes in with early stage low grade mucinous ovarian cancer, I say to them, I think your chances of this cancer coming back are small. I think that the chance of chemotherapy impacting that risk of it coming back is even smaller, and so I wouldn't recommend chemo. If somebody has what we call a high-grade mucinous ovarian cancer, then it's a grey area, a real grey area. So I would probably explain the uncertainty to the patient and say maybe we should think about some chemo.
That's great, thank you very much. The next question we have, someone has asked, do you place any importance on the subtyping of mucinous ovarian cancer into expansile versus infiltrative subtypes? If so, does this influence your treatment?
So I have to be honest and say it doesn't influence my treatment. It's mostly the staging. The stage would be the most important thing for me. Yeah.
That's great, thank you. And you said in your presentation that ovarian cancer is more than one disease. What other cancers are now known to have different types and hence need different treatments? So
actually, to be honest, it's most cancers now. And whether that be, so we broke them down there by histology, and histology is what the pathologist sees when they look down the microscope. But you can break them down further according to the genes that are switched on and off. So actually, each of those subtypes that I just told you about, we could subdivide them even further. And other cancers are also subdivided mostly by histology, but then also by what we call molecular biology, by the genes that are switched on or switched off. And so, you know, if you take breast cancer, for example, there are different histologies of breast cancer. There's lobular, there's ductal, and then there are also different groups according to, you know, whether they express estrogen receptors or not, or whether they express a molecule called HER2. And then another example would be lung cancer, which a lot of well, it's split by histology, first of all, but then also split by molecular. And then the molecular guides what therapy patients get. So really, this is happening in all cancers now.
Thank you very much. And I think just as we're short on time, this will be our last question. But as I mentioned, Professor Gourley's very kindly offered to follow up on other questions. So you will be hearing from a member of the support team if you have asked a question to us this evening. So the last question we'll ask today, please, is it true that 80% of mucinous ovarian tumours are actually metastasis from another organ?
So that is certainly a figure that used to be bandied about, and I think that is what contributed to it being so difficult to recruit to that study that I told you about, that they had to stop before the recruitment got anywhere near complete. What I would say is that I think now our pathologists have got a much better idea of which tumours have come from the gastrointestinal tract, for example, and which have truly come from the ovary. So I think that 80% figure is true in the past. I don't think it's true now. I think if you've got a good pathologist, then they do this stuff called immunoprofiling. So they check what markers are on the tumour. And I think they're much better at working out which are the genuine ovarian tumours.